The traditional approach to mental health often focuses on uncovering deep psychological flaws. But what if much of what we call mental illness is actually just learned behavior? Teodoro Ayllon and Jack Michael, in their 1968 paper, The Psychiatric Nurse as a Behavioral Engineer, fundamentally challenged this medical paradigm.
That's right, Lily. The prevailing view when patients were admitted to a mental hospital was that their disturbing behavior, whether it was self-harm, withdrawal, or a sudden change in conduct, stemmed from some underlying flaw in their mental apparatus. The professional staff, according to the medical model, focused on diagnosing this basic dysfunction, believing that once identified, the right treatment would make the symptoms disappear.
So the focus was entirely internal, on a flaw within the patient. But this paper suggests that during a patient's daily care in the ward, especially under the psychiatric nurses, new disruptive behaviors often emerge or persist. Are these also considered manifestations of that basic difficulty or something else entirely?
Exactly. While some behaviors were identical to those that led to admission, many seemed to originate within the hospital setting itself. Even then, they were typically seen as reflections of the underlying problem. However, these disruptive behaviors, things like refusing to eat, dress, or bathe, or persistently hoarding objects, hitting, spitting, or seeking constant attention, became so persistent they consumed the nurse's energies, sometimes indefinitely delaying any attempt to address the patient's so-called basic problem.
It sounds like the nurses were in an impossible position. They were dealing with these very real, often dangerous or annoying behaviors daily, but the prevailing psychodynamic interpretations from psychiatrists and psychologists rarely offered concrete ways to manage them. So what were nurses expected to do?
The nurses were often left to rely on common sense or physical therapy because the depth interpretations rarely translated into specific remedial actions. Ayllon and Michael, however, proposed a radical shift. From the perspective of modern behavior theory, these strong or deficient behaviors aren't necessarily just manifestations of a mental disorder. Instead, they can be considered the result of events in the patient's immediate or historical environment.
So if the environment shapes the behavior, then changing the environment could change the behavior. That's a huge shift from looking for an internal flaw. Where did they conduct this research to test that idea?
The research took place at the Saskatchewan Hospital in Wyburn, Canada, a large psychiatric hospital. A key feature of this setting was the high degree of autonomy granted to the psychiatric nurses who had undergone a 3-year training program. Psychiatrists functioned as advisors, not commanders, meaning nurses had significant power over patient treatment, mail, visitors, and even discharge.
That's an unusual setup for the time, allowing the nurses to truly act as behavioral engineers under supervision. Who were the patients involved in this investigation?
There were 19 patients in total, mostly schizophrenic or mentally defective, many hospitalized for years. They were specifically chosen because they presented persistent behavior problems that had resisted previous attempts at change. The researchers made clear these weren't necessarily the most severe problems, but their persistence made them ideal for studying behavioral interventions. None of them were receiving other forms of treatment like psychotherapy or electroconvulsive therapy during the study.
So the experiment was designed to isolate the impact of these behavioral techniques. How did they actually measure and track these behaviors before and during treatment?
First, the nurses provided information on the patient's problematic behaviors and any naturally occurring reinforcements. Then, a systematic observation period began. For behaviors involving direct interaction with a nurse, it was recorded every time it happened. For behaviors not involving a nurse, a time sampling technique was used. A nurse would check on the patient at regular intervals, typically every 30 minutes, and classify their behavior into one of 3 categories: the undesirable behavior, an incompatible behavior that could displace it, or neutral behaviors like sleeping or eating.
This seems quite rigorous for a busy ward setting. How are the nurses instructed to implement the actual interventions after this baseline observation period?
The core of the instructions centered on social reinforcement. The pre-treatment studies indicated that much of the undesirable behavior was maintained by the nurse's attention or social approval. So the nurses were taught to either give or withhold social reinforcement. Ayllon described reinforcement as, quote, something you do for or with a patient, for example, offering candy or a cigarette. Any way you convey attention to the patient is reinforcing, end quote. Conversely, to discourage a behavior, the instruction was, quote, ignore the behavior and act deaf and blind whenever it occurs, end quote.
Acting deaf and blind sounds challenging for a caregiver. What were some of the key results, starting with behaviors treated by extinction or a combination of extinction and reinforcement for an incompatible behavior?
In 5 cases, the nurse's attention was identified as the reinforcer. Withholding this attention led to the expected decline in frequency. Take Lucille, for example. She had been frequently visiting the nurse's office for 2 years, interrupting their work. Despite being told not to, and sometimes even physically removed, the nurses had tolerated it, believing she was too dumb to understand. By simply instructing the nurses not to give her any attention when she entered the office, her entries dropped from an average of 16 times a day to 2 within 7 weeks.
That's a significant change just by withdrawing attention. But what about more complex verbal behaviors, like Helen's psychotic talk? That seems much harder to simply ignore.
Helen's case is fascinating. Her psychotic talk, which centered on her illegitimate child and men chasing her, had persisted for at least 3 years, sometimes provoking other patients to beat her. Nurses initially tried to listen to her to get at the roots of her problem, or simply nodded along. This, the researchers realized, was reinforcing the behavior. The intervention was to ignore her psychotic talk, but actively reinforce any sensible talk she engaged in. Her psychotic talk dropped from 91% to less than 25% relative frequency during treatment.
That's quite an improvement, but the paper notes a relapse, with her psychotic talk spiking again. What happened there?
Yes, around the 9th week, her psychotic talk increased dramatically. It turned out a social worker, unknown to the nurses, had been reinforcing her by listening intently to her stories, believing she was helping. This bootleg reinforcement generalized to her interactions with other patients and nurses. The patient herself even told a nurse, quote, well, you're not listening to me. I'll have to go and see Miss, the social worker, again, 'cause she told me that if she would listen to my past, she could help me, end quote. Other uncontrolled instances included visits from hospital employees or volunteer ladies.
That illustrates the challenges of maintaining a consistent behavioral program in a real-world setting. Despite these difficulties, the nurses were somewhat disappointed, expecting a dramatic overall change, not just an improvement in one behavior. This implies a disconnect between addressing specific behaviors and the broader concept of a cure.
Absolutely, and we see this theme again. Another case involved Dottie, who had become increasingly violent over 5 years, attacking patients and staff. She'd had electroconvulsive therapy and even a leucotomy without success. The nurses often resorted to seclusion.
So how did they approach such severe aggression using behavioral engineering?
The strategy was to strengthen an incompatible behavior. A pre-treatment study found that Dottie often exhibited being on the floor, sitting, squatting, or lying down, which was incompatible with violence. The plan was to reinforce this behavior for 4 weeks, hoping it would control her violence and simultaneously reinforce her social approaches to nurses. The problem was, when they tried to extinguish being on the floor in the later stages to promote more normal social interaction, her attacks increased and the nurses terminated the program and returned to restraining her. The strategy of trying to extinguish one reinforced behavior to make way for another was poorly chosen for a violent patient.
A clear lesson in behavioral strategy there. What about patients who refuse to engage in basic self-care, like eating?
That brings us to Janet and Mary, 2 female patients who refused to eat unless spoon-fed by nurses. They cared greatly about clean clothes, but were indifferent to social attention. The intervention involved what they called escape and avoidance conditioning, using food spilling as the aversive stimulus. When nurses spoon-fed them, they were instructed to do it carelessly, letting a few drops fall on their clothes. The patient could escape this by feeding herself after the first spill or avoid it entirely by self-feeding the whole meal. Simultaneously, social reinforcement was given when they fed themselves.
Intriguing and somewhat controversial, I'm sure. What were the results of this method?
It was very successful. In Mary's case, within days, she started reaching for the spoon herself. By the 12th day, she ate all 3 meals on her own. Her weight increased by 21 pounds, and since her admission was due to refusing food and claiming it was poisoned, the success led to her discharge. Interestingly, her claims about poisoned food also dropped out of her repertoire as she began to eat independently, even though they weren't directly addressed.
So, solving the behavioral problem indirectly addressed another manifestation that was thought to be part of the underlying mental illness. And what about hoarding, a behavior that seems to fulfill a specific need for some patients?
For 5 years, patients like Harry, Joe, Tom, and Mac hoarded papers, rubbish, and magazines. Harry, the most serious case, even developed skin rashes from carrying so much. The nurses routinely dejunked him multiple times a day. Ayllon and Michael hypothesized that the hoarding was maintained by the attention it received and by the scarcity of printed material on the ward.
And how did they intervene with hoarding?
The intervention combined stimulus satiation with extinction. The nurses were instructed to flood the day room with magazines and to replenish them every night. At the same time, they were to withhold all attention for hoarding. They would check and tally hoarded items at night, but were explicitly told not to remove them.
So, remove the scarcity and remove the attention. Did it work?
Yes, it worked for all patients. There was a gradual decrease in hoarding, and after 9 weeks, it was no longer a problem. The improvement was maintained for at least 6 months. One nurse had initially questioned the advisability of changing Harry's behavior, arguing, quote, "Behavior has its roots in the personality of the individual." The fact that he hoards so much indicates that Harry has a strong need for security. I don't see how we are going to change this need, and I also wonder if it is a good thing to do that, end quote. But Harry simply transferred his security needs from hoarding trash to sitting in the day room looking at magazines without any apparent discomfort.
That's a powerful counter to the idea that these behaviors are solely expressions of deep-seated psychological needs that shouldn't be interfered with. It suggests that even if there's an underlying need, the expression of it can be modified. What were some of the broader implications and challenges of this work?
A major challenge was using nurses as experimental assistants and data recorders. While not as precise as laboratory equipment, Ayllon and Michael found the nurses' errors were mostly unsystematic and didn't invalidate the work. They acknowledged that dealing with subtler aspects of behavior would require even more refined techniques.
And what about the staff's acceptance of this approach? This was quite revolutionary for its time.
Staff attitudes were mildly favorable with some enthusiastic support. Nurses didn't feel overburdened. The time spent on observations and recording, about 40 minutes per 8-hour shift, was seen as an excellent investment if it eliminated problem behaviors. However, there were 2 key misunderstandings. First, nurses often didn't recognize problems if they weren't dramatic or considered them unsolvable, attributing them to diagnosis or age rather than environmental factors.
And the second misunderstanding seems to go back to that "so what" attitude you mentioned earlier.
Precisely. Even after a behavior changed, nurses would sometimes say, quote, "We've changed her behavior, so what? She's still psychotic," end quote. They tended to be dissatisfied with anything less than a total cure, forgetting the previous importance of the specific problem behavior once it was eliminated. This highlights the gap between addressing specific behaviors and the often vague, unarticulated expectations of a complete psychiatric overhaul.
It raises the critical question of whether these behavioral changes are temporary. If the environment is key, what happens if the environmental controls are removed?
That's a valid objection. Ayllon and Michael argue that permanent elimination of ward behavior problems requires a permanent elimination of the environmental variables that shape and maintain them. They suggest the clinical belief that a favorable behavioral change, once accomplished, will be permanent, rests on a faulty evaluation of environmental variables. It's not, they say, based on actual accomplishments in mental health.
So Ayllon and Michael's work, The Psychiatric Nurse as a Behavioral Engineer, truly demonstrated how systematically manipulating environmental factors could effectively modify even long-standing, challenging behaviors in psychiatric patients, emphasizing the profound influence of context over inherent flaws. If you found this discussion thought-provoking, please share this episode with someone who might also appreciate it.